So here we are into the practical applications of immunology. We are totally done with describing the structure and function and engineering design of the entire system. So I think you'll find that our remaining discussions here are not only extremely practical for what you need to know to be a practicing physician, but they're also going to be fun as we see what the applications of our knowledge are. So, one of the places where incredible amounts of medicine interface with immunology is in the discussion of how we protect patients before exposure or potentially deal with them after they've been exposed by giving immunotherapy. So we refer to the types of immunotherapy we do as either active or passive, which implies, of course, either I'm doing the response myself or else I am giving the patient some product that they have not had to make themselves. So you probably know from just the little time we've spent together that my philosophy would be that if you have an option, the best way to build your immunological muscles is both actively and naturally. Getting sick and recovering is the most powerful way of building your body's control. But there are conditions where we have pathogens who would have a very high mortality rate. And so in those cases, in my humble opinion, the next best thing is what we do when we artificially induce active immunity by vaccination. Now, we're introducing an altered material that hopefully has less virulence, but the response we get is an active response where the patient is making their own immune response. And as such, it will have memory and amplitude and all of the things that we have talked about so far. There are certainly Mother Nature's versions of passive immunity. The child is receiving immunoglobulin across the placenta from the mother during gestation, and also breastfed children are receiving IgA from their mother. Those are preformed products being donated from mother to child, but it's a perfectly natural process that is designed to protect the child during a period of time when they're not strong enough to make an immune response of their own. Now, the one that is last on the list here, passive and artificial, is what we do when we have a patient who is at risk and has been exposed to a pathogen in a case where we do not have the luxury of time. Remember that those things that we've been working through for quite a bit of time now in the immune system strategy, those things take at least 10 days to 2 weeks to have a full-blown evolution of their strength. So if we do not have 10 days to 2 weeks to get a patient to make a response of their own, then what we have to do is artificially give them the products of an immune response that might help them through the worst of the disease. And as you'll see, as we finish this chapter, that is actually the most dangerous of the means of immunotherapy on this list, because it causes the patient to be given a material that they may learn to regard as foreign and make an immune response against. But of course, when we have no options, when the patient has received a toxic spider bite or a snake bite of venom, or when they're immunocompromised and they've been exposed to a serious pathogen, in those cases, we weigh the benefit versus the risk, and passive immunotherapy is what we do. Now, when we talk about vaccination, first of all, realize that we have several things that we have to keep in mind as we do so. In the first place, we have to consider what is the natural immunological capacity of the age group of patient that we're speaking about. In the case of children, as you might imagine, they have an immature immune response, and so we have to be cognizant of what we're asking them to do in the context of what they're actually able to do strategically. We also have to keep in mind the epidemiology of the pathogen we're trying to protect against, because there are some things that are respiratory, there are some things that are sexual or parenteral, and so knowing the times in a patient's life when they would become susceptible to a given pathogen, of course, factors into what we want to do for therapy. Finally, the mechanism of pathogenesis of a particular microbe and the best immune response to protect against it is the final thing. Realize that not all pathogens would be protected against by the production of an antibody, and similarly, some pathogens would not be protected against by turning on a cell-mediated immune response. So we have to tailor the therapy for what we're trying to achieve as a protective device. Now, I don't want your eyes to roll back in your heads as you look at this chart. This is available at any time you would like to see it at the address down here. The Centers for Disease Control puts out a yearly vaccination protocol. But realize that this is the current protocol for vaccination of children in the United States that you will become very conversant with as you move into your pediatric rotations. But our purpose here is not to have you memorize what the vaccines are and when they're administered and how many boosters there are. Instead, we want to talk about the strategic planning of why a particular vaccine would be given at a particular time and what would be the anticipated result from using that vaccine. So notice that as I think about that, I have to keep in mind what I know about the development of the immune response in the child. And this diagram, what I'm trying to show you here, just for a little bit of interpretative help, is that when the bar becomes at its widest, that is the point that that particular issue has come to be at an adult level of expression. So even though it appears perhaps at first blush that I'm saying that there's no response of T cells, what I'm actually saying is that at birth, a child has fully competent T cells ready to go at the adult level. But remember, this is a naive animal. This is an individual who has not experienced the necessity for a response. So that's going to take some time in order to get those cells out doing their job. But the capacity of T cells at birth is the adult capacity of T cells throughout most of the life. Now notice the other things here. If we look at the innate immune response, notice in general, it takes up to a year to have a full adult representation of things like complement, slightly less than that for natural killer cells and dendritic cell activity, and neutrophils would be functional fully at birth. But the longest term for development are those things that require antibody synthesis, particularly for those isotypes of antibody that are more highly evolved in the sequence of the germline DNA. So remember, children would make IgM and IgD fairly naturally, and they would be protected by transplacental donation of IgG from the mother if they have been carried to term. Breast milk is going to give them the IgA they need for at least some period of time until they can make their own. But when we consider the types of molecules that will elicit an appropriate response of antibody type, notice that those that depend on T cell help are going to be much more quick to evolve than those that are present in the absence of T cell help. And this is a very important strategic thought as we vaccinate children. Realize that if you do not provide protein in the vaccine, remember, protein is what the T cells respond to. If you do not provide protein in the inoculum, the child will develop a very weak immune response to that particular molecule. And it's true overall that children are not making adult levels of all isotypes of immunoglobulin until they are about 5 years of age. So now when we think about that, I think you should be thinking about the fact that it's true that pathogens that get into the child across a mucosal surface are going to be the ones that I want to protect against early on, because I see that window in the child's expression that they would be susceptible to that, particularly if they're not breastfeeding. And you'll notice when we talk about children who are delivered prematurely, it becomes a major issue that you understand that the placental IgG receptors that are shunting IgG into the fetal circulation really are not maximally expressed until 28 weeks of gestation. So if I have a child born before that time, I am especially going to have a child susceptible to things in the immediate postnatal period. All right. Now, what it says below is exactly what I said to you talking through the diagram, so I won't read through that. Let's now talk about what the types of vaccines are that we have. And so those that we administer against bacterial microbes are ones by and large that have one of two strategies. They are either attempting to make an antibody against the toxin of the bacterium, and when I say toxoid, I'm simply referring to a toxin that has had its virulence inactivated. So a less harmful, but still a protein product of a bacterium. So if you notice my bacteria that I'm speaking about here, we have C. diphtheria toxin, we have Clostridium tetani toxin, and we have the toxoid of Bordetella pertussis, all included in the DTaP vaccine. That abbreviation stands for diphtheria, tetanus, and acellular pertussis. Back in the day, they used to use whole-killed Bordetella pertussis, but there were some rare sequelae to that were unfortunate, and so they have switched over to using the filamentous hemagglutinin that the organism uses to attach to mucosal cells and the inactivated toxin. Now, if you remember in advance, before we do our micro together, realize that the toxins of bacteria are all proteins. So it means that by definition, that these materials have the immunogenicity necessary to turn on the production of T cells to assist in antibody production. And the response of the child, once inoculated appropriately, is going to make antibodies against the toxin, or antitoxin antibodies. Notice that the rest of the vaccines that we use in childhood deal with the unusual susceptibility of children to mucosal entering pathogens. And so in the case of Haemophilus influenza, in the case of the pediatric strep pneumo vaccine, and in the case of the pediatric meningococcal vaccine, realize that in each of those cases, we are trying to get the child to make a response against the capsule of the organism. Now, the problem with that is that capsules are universally made of polysaccharide. I said universal, and actually there is one exception to that. Bacillus anthracis makes a polypeptide capsule, but all the remaining capsules of all the remaining bacteria and fungi who have them are made of polysaccharide. And so realize that's a T cell independent antigen. And that means that if I don't do something about that relative to the child's ability to make that response, I'm going to get a very poor response. So what they learned early on to do is to conjugate those capsular polysaccharides to an unrelated protein. And the protein that they have used in each of these cases is the diphtheria toxoid. Now, in case that seems rather strange to you, realize that back in 1990, when we were having an unbelievable outbreak of H. flu meningitis that was extremely scary and frightening parents globally, the vaccine manufacturers went to the Food and Drug Administration in the United States and said to them, we have an idea, based on our understanding of how the immune system works, that if we can covalently couple that capsular material to a protein, then we can get a much stronger and better and more successful response in the children we vaccinate, and perhaps we can stop this amazing outbreak that we're seeing. And the Food and Drug Administration said, well, you're going to have to go through 10 to 15 years of clinical trials to get that on the market. If you use a new protein, how about taking a protein we already know is not harmful in children? And so they took the first letter out of DTAP, they covalently joined it to the capsular polysaccharide, they tried it with Haemophilus influenza, and it was such a roaring success that they then repeated it with strep pneumo capsule and with meningococcal capsule. So the success of that idea of protein conjugating in order to make a T-cell dependent vaccine in this age group was really a tremendous breakthrough in medicine, and one that you probably should be aware of. Now, in those cases, of course, the protein is acting as the carrier, and the capsular polysaccharide is acting as the hapten. So if you're ever trying to figure out who is making what in this response, remember it's my B cell who is seeing the hapten material. It has a receptor for the polysaccharide. It is the T cell who is responding to the carrier. But as long as these two are joined together, I'm going to get all of those cytokine signals and co-stimulatory molecules and so forth that I need in order to make a full-fledged, full isotype response with memory. The pediatric viral vaccines, realize in this case we have 3 different types. We have those vaccines that are live and attenuated. These are the ones where the viral agent is still capable of carrying out its life cycle, but it has been minimized in its virulence by using some particular technique. Also, we have those that are killed, where the virus itself is inactivated so that it cannot cause any life cycle to occur in the human that is inoculated. And then finally, the most recent development has been the onset of those that are made by recombinant DNA, where we actually find the molecule and the genetic coding for it. We clip that out of the organism, put it into another organism like E. coli, and cause it to make that molecule. And then we use that purified molecule as a simple single injection. So realize the only one of these styles of vaccines that is actually going to cause an infection in the patient and therefore get the best and strongest immune response to result is the ones who are the live attenuated ones. But I always have to remember that when I am measuring the risk versus the benefit ratio in a given vaccine, that I have the potential for danger if I use a live attenuated vaccine in someone who is immunocompromised. Now, just some memory tools here for you as we go. I always start with these by the mnemonic "rest in peace always" being the way that I remember the killed vaccines. Rest standing for rabies, In standing for influenza, peace standing for the sock of polio, and remember that K should tell you that it's a killed vaccine, okay? And then the A is for hepatitis A. If I know those four, and then I add on the two that have most recently been created, the hepatitis B vaccine and the human papillomavirus vaccine, then by process of elimination, I can just remember that everything else is live attenuated. So there's a big list of the live attenuated ones and much smaller numbers of killed or recombinant DNA. Now, when we think about why these would work the way they would, we have to keep in mind not only what's in the vaccine, but the route by which it is administered. Because remember, in our discussion of how antibody responses are created, and indeed any immune response, your immune system understands the entry mechanism for a given pathogen. So that if I want to create the most beneficial protective response, it's a good idea to create it locally where I need it to be exhibited against the real pathogen. So notice that I highlighted in yellow those cases of vaccines, regardless of what their type is, if they are administered across a mucosal barrier, it means that my immune response is going to be in that specific area. And so all of my memory and my response will be targeting that natural mode of entry for the pathogen. Now, of those that are live and attenuated, notice they create both cell-mediated and humoral. Because they are a living creature, they are going to be regarded as a living creature, undergoing a normal life cycle, stimulating cells by binding through TLRs 3, 7, 8, and 9, eliciting interferon gamma, which signals to the APC that it should become a classically activated APC and make interleukin 12, which will then stimulate the T helper 1. And then also I'll have the spillover of making anti-APC2s and T helper 2s as well. So the entire amplitude of the immune response is going to be created with a live attenuated vaccine. And furthermore, if I deliver a live attenuated vaccine across a mucosal surface, then realize not only do I have the strength of the entire system behind me, but I also have it directed specifically at the entry point that that pathogen prefers to use. Okay, so I will leave this with you to look at more fully. But if you're ever asked what are the strongest vaccines, it's the live attenuated and mucosally delivered ones that produce the best and most efficacious immune responses. But I always have to remember that those are more dangerous in someone who does not have a full-fledged immune response, like someone who is immunocompromised. Now, one more thing before I leave this, I want to mention to you the explanation of the word adjuvant. An adjuvant is something that is added to a vaccine in order to increase the speed and amplitude of the immune response. It's not going to change the nature of the immune response. If it was going to be antibody production before, it will still be antibody production with an adjuvant. But the difference is that they're believed to cause nonspecific inflammation. And I hope you remember that acute inflammation is a natural way of increasing the infiltration of cells and proteins and speeding up the response of the adaptive immune response downstream. So the only adjuvants we use nowadays in the United States, alum and calcium phosphate. If you guys have ever had any vaccines recently as boosters, you would probably know the ones that contained adjuvants because you would feel that they sting when they're administered. That sting is from the adjuvant. It's not from the material that's actually the immunogen in the vaccine. And remember, we do not use those in any live attenuated vaccines because of the fact that if I'm putting chemicals into a vaccine, I have a very high likelihood of killing the virus. And if I do that, then I have stopped the ability of the immune response to recognize it as an intracellular pathogen. From there on, we need to consider the vaccines that we use in special populations of patients. And again, I'm going to leave this with you. This is also from the Centers for Disease Control site. But I want to point out some things that you should be aware of. If you notice, we have some cases where vaccination is actually contraindicated. And you should know the vaccines that are not given during pregnancy, the ones that are not given to immunocompromised patients, and so forth. And if you'll notice when you look at the list, what they have in common is that they're all live and attenuated. Beyond that, realize that we have a special protocol for vaccination in patients who are asplenic because asplenic patients have problems removing encapsulated organisms from their blood. So you'll see that. And then other than that, it's pretty straightforward what the recommendations for repetition are. If I'm trying to create an antibody response, I have to boost at 10-year intervals. If I'm trying to make a cell-mediated immune response, I might need to talk about that happening after 40 or so years. Now, the problem with this in adults is the issue that most of us in this room today are during the period of life when we have a quite active immune response that we have developed throughout our childhood. And now we have a fully fledged immune response involving antibody and cell-mediated immune production. But as we reach our later years, notice that the decline of the number of T helper cells is fairly prominent. And so the immune response begins to wane over that period of time, and thus the necessity for increasing vaccination boosters in that group. It's also true that in general, pregnancy is an immunocompromised state. It's not a profound state of immunocompromise, as would be a transplant patient, etc. But it certainly is a state when we can anticipate the mother is going to be increasing her expression of regulatory T cells, which of course keep her tolerant to that fetus, and simultaneously decreasing the amounts of T helpers and T helpers of both active types. You'll notice that the T helper 2 is ramped up late in pregnancy, but all of those antibodies that are eventually produced are being pumped into the child. So the net effect in the mother is one of immunosuppression. Okay? And we talked before about the fact that children start out with a generally tolerant view of their environment, which then falls down to the adult level, which stays more or less at a low level as long as T helper 1s and 2s are doing their job to protect against infection. The vaccines for the elderly listed here, we have the varicella zoster vaccine, a live attenuated vaccine, or one that's made by recombinant DNA. They are currently recommending the recombinant DNA one, although as an immunologist, I have to tell you that I would make the argument that in a healthy, normal, well individual, it would be the live attenuated one which would turn on the better immune response. I think the current recommendation via the American Medical Association for the elderly to use the recombinant DNA one is basically accepting the fact that as we age, we become less immunologically competent, and therefore it's simply not wise to take the chance. But I would tell you that when I turned 60 several years ago, my vaccine that I received against shingles was the live attenuated one, and I'm happy to have gotten it. I have a very strong immune response. But I know that the current recommendation to be safe is the recombinant DNA one. The current recommendation for protection against pneumococcus is 1 dose of the pediatric vaccine, and that stands for PCV, pediatric conjugated vaccine. That's the one that's conjugated to protein. And then yearly boosters of the one that is purely capsular polysaccharides. The reason for that is that the one that has only polysaccharide has a much larger number of capsular antigens included. So we set up the response with a T cell dependent stimulation, and then we boost with purely the capsular material for the sake of getting a broader range of protection across multiple serotypes. For influenza, yearly, intramuscular, killed. Realize we have to do that with influenza because of its high rate of genetic shift, which we'll talk about in virology. And then, of course, tetanus and diphtheria for 10-year boosters. Finally, let's talk about passive immunotherapy, because if I don't have enough time to have my patient work through an immune response of their own, then what I have to do is I have to provide them with the preformed products of someone else's immune response. And the reason why this is really a preferred last course scenario is because of the fact that I need to remember that immunoglobulins, when I give them to a patient, are glycoproteins. Glycoproteins are immunogenic. And so a person of one genetic heritage can actually recognize the immunoglobulins of another human being as being foreign. Now, if you think back to how we talked about immunoglobulin molecules, remember, they're basically a Y-shaped structure, okay, held together by a hinge. And we have both variable domains at the N-terminal end, which define what I call the idiotype, right? And then we have the constant domains downstream, which define the isotype of the molecule. Well, I have another word for you here now, and that is allotype. And what allotypes are is simple amino acid differences in the constant domains of the molecule, both the heavy and the light chain, but they are genetically determined as having been given to you by your parents. So a person with one genetic heritage could have different allotypic markers in those regions than the person who's donating the serum for their treatment. So what can happen then is that those allotypes can be recognized as being foreign, and an antibody of the recipient can be made against the antibody that is donated. And when that happens, I have created an immune complex, an antibody against an antibody, by definition, an immune complex, and my patient may develop type 3 hypersensitivity, which we will discuss on another day. Even more dangerous than this would be if I were to make an IgE isotype of antibody against those allotypes, because in that scenario, now I could cause a type 1 hypersensitivity and a fatal anaphylactic response. So simply keep it in the back of your mind that it's always more dangerous to give a patient a preformed product from another human being because those naturally can be seen to be foreign and an immune response can be made against them. All right, we are at our magic hashtag Make Me Care time. So you know the rules by now. I will explain the question to you. I will then suggest that you pause your video and think through your answer. This is really only valuable to you if you are able to work this material in the way that you need to, so that when you're confronted on exam day with something you've not thought about before, you have a plan for solving the problem. Okay, number one. Patients with selective IgA deficiency are at high risk for development of anaphylactic responses against minute amounts of IgA contained in matched whole blood transfusions. Can you imagine why this is so? All right. So let me bring you back to answer this question to our discussion about the germline DNA in the B cell. Remember, I have V, D, and J. Then I have the constant domains for mu, the constant domains for delta. Then I have 4 switch regions, which encode gamma. I have 1 of alpha. I have 1 of epsilon. And I have a final 1 of alpha. So if I tell you that a person cannot make IgA, it means that these 2 switch regions are non-functional. So in that scenario, the only thing downstream from gamma is epsilon. So if I continually stimulate a B cell to switch isotypes, it should make sense to you that these patients have a very high risk for making IgE in response to unusual things. I see this in transfusions sometimes, and I can get a fatal anaphylactic response from this. And indeed, what is being responded to in that scenario is the allotypes of the molecule that are being recognized as something that this patient has never seen before. Okay? Number 2. Why is it that live viral vaccines are not given before 6 months of age? Pause your video and think. Well, if you think about what the child is doing in those first 6 months of birth, realize they are protected by maternal antibodies that were being pumped into the child transplacentally. So for that first 6 months, if I were to administer a living viral vaccine to the child, it's not that there would be harm, it's simply that I would not get the result I wanted. Because the first thing that would happen would be that the maternal antibodies would bind to those living virions and would stop them from starting an infection, which is necessary for that type of vaccine to make a good immune response. So I actually have the maternal protective antibodies stopping the baby from being able to make an immune response to themselves. It's not necessarily going to harm the child. It's simply that I'm not going to get the result. So why bother waste the time doing that? Number 3, a child is born with positive specific serology of IgG isotype against HIV. Is this diagnostic? Please explain. Pause your camera and I'll be back in a second. Well, again, a child who is carried to term is going to be receiving IgG from the mother from the 28th week of gestation onward. So having IgG in the child, although it could technically mean that the child made that immunoglobulin, the likelihood is that the majority of it came from the mother. So realize that I cannot use IgG measurement in a neonate to determine if a child has received an in utero infection. Now, by contrast, if I measured IgM in that child, if I had said to you specific serology IgM isotype, that would tell me indeed that the child was infected. But of IgG isotype, I can't tell the difference between any that the child might have made and what the mother made. So I have to use a different technique for determining infections in neonates. I either have to look for IgM, and there are some scenarios where we do that in utero suspicion, and there are others, like HIV, where we actually need to look for the virus instead of looking for antibodies. And in a child born to an HIV-infected mother, we actually look for the provirus, which is what we call the virus already integrated into the chromosomes of the host cell. And we do that by PCR. Okay? Number 4. Can you predict when children will first present with primary immunodeficiencies involving antibody synthesis? Well, remember, children will not reach adult levels of antibody synthesis until they're at least 5 years of age. And if we're talking about a child who has a primary immunodeficiency of antibody synthesis, it would not be normal by the time they reached 5. But in the early months after birth, around 6 to 9 months after birth, a child is protected by maternal antibodies. So during that period of time, the child would not have a greater number than normal of infections with any pathogen around. So most of my primary immunodeficiencies that involve antibodies are going to manifest after that period of time when the maternal antibody is no more. So 6 to 9 months after birth would be about the earliest. Okay, number 5. Premature infants delivered before 28 weeks of gestation are at high risk for respiratory and systemic pathogens. Based on what you understand about the development of the gestational and pediatric immune response, should the vaccination schedule for preemies be age adjusted? In other words, should vaccines be delayed to correct for the gestational age of the early delivery? Well, this is actually a difficult question that I don't know that we will arrive at an answer for today, other than to say that this is probably going to be determined on a case-by-case basis. The thing that you need to think about is that even though the child has not received the protective antibodies from the mother if they are born before 28 weeks, they still will have the ability to produce a response of their own with fairly good strength as long as it's a T cell dependent response. Because as you remember, their T cells are adult capable at birth, even if they are born prematurely. The problem becomes that I always have to think about the lack of that maternal antibody and the need perhaps to institute stimulation of the child's immune response in the absence of that. So I might not want to hold off any longer in vaccinating because I have to remember the child didn't have that protective response from the mother. So really it ends up being a case-by-case basis of evaluating what is the likelihood that this child could be exposed to something that would be dangerous, and what are my chances that that immune response would be capable of being turned on at that stage of gestation. But normally, we do not. We normally use the same policy even in preemies, although that conversation is still ongoing. Number 6, our last one. The adenovirus vaccine developed by the military uses live virulent respiratory strains of the virus, but it causes them to be administered in an enteric-coated capsule. Okay, can you explain the strategy here? All right, so this is the only example that we will talk about of a virulent strain being included in the vaccine. Nothing has been done to this virus to stop it from causing dangerous infection, except that it's being given in an unnatural way. Normal respiratory adenoviruses would attach to the upper respiratory mucosa, and they're not capable of surviving the gastric acidity. But when we deliver them in such a way that they make it through the stomach, they start an infection on the gastrointestinal mucosa, and that immunity, needless to say, is going to be both cell-mediated and humoral. It's going to be mucosal in its origin. And so where I'm going to get my memory is on mucosal surfaces. So when the individual is then exposed to the real respiratory technique of inoculation, which is natural, what's going to happen is that memory cells created on the gastrointestinal tract will go to the other mucosal surfaces and wait for the pathogen to enter. So it's the only example of an unattenuated vaccine that is given, and it's a very clever technique which maximizes the value of the location where the immune response is being made, as well as the nature of the immune response being elicited. So we have finished our, our discussion of vaccination and immunotherapy. As always, I am not going to read the list of things that I want you to be familiar with, but please don't ignore them. Make certain that you can work through each of these in your mind so that you are certain that you have gotten the lessons out of this chapter that you needed. All right, and I will see you next time.